So good morning, dear friends. Today we are going to have another session of hematology on hemophilia. Dr. Kanwaljeet will be taking the session today. She is the associate professor and senior specialist in Department of Pediatrics at Postgraduate Institute of Medical Sciences at ESI Basai Darapur Hospital. She has been actively involved in patient care and research, and she has more than 20 publications in various national and international journals. So I request Dr. Kanwaljeet ma'am to please start the session. I'll be sharing the screen. Stop sharing the screen. Ma'am, please start sharing this.
Sure. Is my screen visible?
Yes, ma'am.
Good morning, everybody. At the outset, I would like to thank organizers, especially Dr. Ajay Gupta, as well as Dr. Jagdish Chandra sir, for giving me this opportunity. Today, I'm going to talk about management of hemophilia and von Willebrand disease, which is a common hereditary coagulation disorder. Brief outline about the topics covered today in the presentation. So coming to our first case, a 6-year-old male child who presented with swelling, pain, restriction of the right knee joint here, history of pyknosis in past, as well as family history significant. So looks pretty much straightforward, but we need to look at the differential diagnosis. A brief about mechanism of hemostasis in a simplified manner. Whenever there is a breach of endothelium in the vessel or in a tissue, the platelets are attracted. So this is an unactivated normal looking platelet which comes to the side and then the process gets activated and you can see a lot of pseudopodia formation in the process. This platelet plug form is quite unstable and does not sustain for long, and hence we need a coagulation system. As a final common pathway, factor 10A in presence of factor 5A activates prothrombin to form thrombin, which in turn activates fibrinogen monomer to form a fibrin. And this fibrin monomer forms strands with other such fibrin monomers, leading to the formation of a stable clot in contrast to the platelet plug we had in the beginning. So this is the essence of the coagulation system, and that is why it is important. We can tell clinically also what we are looking at, what is the likely etiology before we start screening for the coagulation disorder or bleeding disorder. Clinically, how we approach this table you might have seen before also. So the site of bleeding is important. If it's deep, muscular or joint bleed, likely coagulation defects. Also, the patient does not bleed after minor cuts. So patient may come after trauma. There may be some scrape on the knee joint, but that scrape healed well. But the joints swell, and this bleeding occurs in the joint, but it's little delayed. So by the time the scrape has healed, now you see that the patient has joint which is started swelling. Also, the patients may present with echinosis, hemarthrosis we discussed already, and this is a chronic patient, a chronic stable looking patient who comes with a history of recurrent bleeds. Think at the etiology of the coagulation defect, whether it is congenital or acquired. So we need to look at the history, past history of the patient, how the patient fared when the patient was born. So that history is very important.
Ma'am, can you please increase the volume of your mic? From the audio settings, just near the mic, there is a button on the bottom.
This microphone or speaker? Audio set.
Yeah, if you audio settings on the bottom, there is audio settings. Select microphone, then you look at the bottom, audio settings.
Yes, I went to the audio settings. Now there are two types of settings, input and output. level,
Output. Yeah, increase the mic.
speaker and the mic.
Input in the input microphone. Go to the input. Increase the
Higher
volume.
It's not going up, sir. Automatically. Shall I give
Oh.
it the automatic? Okay. No, maybe this one. Yes.
Oh.
Any better, sir?
Yeah, now it's better.
Thank you. So we need to look at the history, how the child fared at the birth. Right. So is there any prolonged history of prolonged bleeding from the umbilical staff? Was there any significant profile hematoma? And if any circumcision was done, how was the bleeding controlled at that time? And especially regarding tooth eruption and fall, the patient may have significant bleed. Family history is the most important part in such cases, and a clinically well-looking child, as we discussed earlier. So we do come across patients with bleeding. We need to know how significant the bleed is to decide to what extent we need to proceed for the testing. More than one site of bleeding is always significant. Either it is spontaneous or provoked. If it is a single site bleeding, still it could be significant if it is severe enough to require medical attention or blood transfusion, or there are 3 or more episodes on separate occasions. Also, family history is important. If the family history is there, then likely we are dealing with a significant disorder. This is a pediatric bleeding questionnaire scoring key to quantitate the pre-test probability of having a result which is likely to be positive. So in adults, we have bad bleeding assessment. In pediatrics, we have pediatric bleeding questionnaire, which is different from the adult questionnaire in the manner that there is a other category, how the child fared in the neonatal period, and also the cutoff is less than 3. So we have a lower threshold of diagnosis. We don't want to miss any bleeding infant or child. Coming to the congenital coagulation disorders, hemophilia A, as we all know, is caused by factor VIII deficiency, B with UP9 deficiency, factor C, it's a very rare, isolated in some families only. It's factor 11 deficiency, it's autosomal recessive, and von Willebrand disease we all have heard of and is the most common congenital coagulation disorder. X-linked recessive disorders, females are carriers but may suffer from symptoms of hemophilia. We'll come to that in detail later. Incidence of hemophilia A is approximately 1 in 5,000 males, and hemophilia is 6 times less common, 1 in 30,000 males. Positive family history is there in 2/3 of cases, but it is not a must because de novo mutations occur in 1/3 of cases. So that is why it is important, because we cannot actually completely eradicate hemophilia by genetic screening and all that stuff, because de novo mutations do occur and they contribute to the significant burden of the problem. It is an ancient disease, Talmud in 2nd century mentioned that if there are 2 sons of a woman who have died of hemophilia with no circumcision, the 3rd one should not be circumcised. Moreover, he says that the sons of the woman's sister should also not be circumcised, but the sons of her brother can be circumcised. Such an intelligent observation, how old, like 2nd century. So 1600 years later, hemophilia was described in modern literature, and hemophilia B was recognized in 1952. It's also known as royal disease. Queen Victoria suffered from hemophilia B, and she was a carrier of hemophilia B and passed it on to her descendants. Besides British Empire, Swedish, German royal families, and Russian czars have also been suffering from this royal disease. Clinically, they present with joint bleed, which is the most common presentation, 70 to 80%. Muscle bleeds, and fortunately, CNS bleeds are the least common. And when they present, they may have a feeling of aura. They may feel like numbness, tingling in the joint before before the joint actually swells up. So that period, that aura is important because at that time the patient can opt for factor 8 administration for the breakthrough bleeding. Site of bleeding in hemophilia could be serious or life-threatening. So joint muscle bleeds, they are all serious bleeds that we commonly talk about. But life-threatening bleeds, if they happen like intracranial bleed, neck and throat bleeding, intraperitoneal bleeding leading to massive blood loss, and patient may go into shock. This history is important for any patient. Whenever we are taking, besides labeling the patient and with the accurate diagnosis, significance of the bleeding history is also important because that determines what kind of prophylaxis we will give to the patient. This is a screening evaluation that we all are familiar with, looking at the CBC platelet count, as well as looking at platelet number, confirming the platelet number on peripheral smear, looking at the size and the morphology. Besides this, the coagulation profile. Population cascade that we all were scared of during our MBBS days. So I have tried to simplify it so that you don't have any difficulty remembering it. So the extrinsic pathway, we can label it as PT pathway, prothrombin time pathway. The intrinsic pathway, we can label it as prothrombin time pathway. They both merge at factor 10. So this is like a crossing point of both the pathways, which works in conjunction with factor 5. We can visualize it as something fitting into the notch of factor 10. So this is the common pathway involved in the prothrombin time and the PTT pathway. And this ultimately leads to activation of prothrombin to thrombin and thrombin activates fibrinogen to fibrin that we already saw. I have borrowed the slides from Dr. Cecil Ross, and it was an excellent presentation that I attended to, and I would like to, that is why I wanted to share this. Looking at the coagulation cascade, the PTT pathway. So looks little complicated. How to remember it? 10. So 12, 11, 9, 8, 10. So this is the mnemonic that we use to remember this complex for the PTT pathway. This complex is also known as 10As because it lyses factor 10 to factor 10A. Factor 8 leads to hemophilia A, 9 deficiency leads to B, hemophilia C, and factor 12 leads to isolated prolongation of the APTT without leading to any defect in the coagulation pathway. So the patient doesn't come to us with a history of bleeding. When we are normally screening this APTT prior to surgery, then this factor 12 deficiency may be diagnosed. Luckily, factor 7 is the only factor in the PT pathway, making our life little simple. How the sample is collected is important in the interpretation of the results. Whenever we are taking the sample, it is important that the clean venous puncture should be there. We should not be squeezing the blood for collection of this much of blood sample because tissue factor released during the tissue trauma will alter the interpretation of the reports. And this blood should be filled up to the mark. If it is less than 20%, this is 20% deficient, then we cannot interpret the results. The results will be prolonged. This should be processed rapidly. It should not be stored in refrigerator or in heat. 18 to 24 is the optimum temperature. Both the refrigeration temperatures and the heat lead to altered reading of the APTT and PT test. As well as it is important, the patient should not be stressed. So we should be having a rested patient before we draw the sample. Coming back to our case, the platelet count came back normal, PT was normal, and APTT is prolonged. The swelling is also gradually increasing, and what to do next? The next test is the mixing study. In the mixing study, what is done is the patient's plasma is mixed 1:1 in 1:1 dilution with the pooled plasma, which is assumed to be 100% factor 8, 9, and 11. So after mixing, we incubate it for 1 to 2 hours at 37 degrees centigrade. The pooled plasma after 1:1 dilution will get diluted to 50%. So our APDT is corrected by a level of approximately 20% of factor. Factor is enough to bring the APDT to normal. So this APDT is now corrected. This means that the factor was deficient. When the inhibitors are there, they are binding to factor 8, which is there in the circulation. We add more of factor 8 or 9 in the pooled plasma and we incubate. After incubation, we repeat the test and the APTT does not correct because the inhibitor is there in the plasma and whatever factor 8 we have added is not enough to neutralize whatever inhibitors were there. So the APTT stays prolonged. If the APTT stays prolonged, probably we are not dealing with a deficiency and we need to look at a different cause. We'll come to that. Next slide. So if APTT is not corrected, we test for lupus anticoagulant. If lupus anticoagulant is positive, our diagnosis changes. If lupus anticoagulant is negative, we are probably dealing with some inhibitor of clotting factor, a specific inhibitor of the clotting factor. To summarize, the diagnosis of hemophilia involves screening with above tests, PT, APTT, platelet count. Then we confirm the diagnosis by mixing study, which will identify whether the factor is deficient or the inhibitors are present. In some cases, we can diagnose the deficient factor that was done in olden days by mixing studies with specific factor deficient. So we can use either 8 deficient plasma, 9 deficient plasma, and that will help us in diagnosing which particular factor might be deficient. We can also confirm the diagnosis by factor assay, which will also help us in determining the severity of the disease. So less than 1% is severe, and this is the most dreaded type of hemophilia, where the patient may bleed spontaneously in the joint. Muscles may have higher incidence of life-threatening bleed. Moderate and mild hemophilia are less likely to bleed spontaneously and they bleed with major trauma. In our case, the mixing study showed correction with the pooled plasma. Since it was corrected, the inhibitors was not the diagnosis, deficiency was the diagnosis. And this was followed by factor assay because we wanted to know how much was the factor level, which will help us in determining the severity. And this severity also helps us in determining what kind of prophylaxis we will give, whether the patient will need prophylactic factor replacement or not. So it's important to know. But this factor 8 level, less than 1% or 5%, it does not confirm the diagnosis. We need more tests. We need to rule out von Willebrand disease. What happens in von Willebrand disease is that the factor, either antigen levels are low, or their binding to factor 8 is defective. In that case, factor 8 levels would also be low. So no diagnosis of hemophilia A should be made in the absence of von Willebrand factor assay. Factor 9 levels should also be tested. Rarely families have been reported where both the factors have been deficient. So case reports are there. Now we have a diagnosis of severe hemophilia. And you suggest genetic testing, which family refuses. So the question comes, do we really need genetic testing in all the cases? Whom to test? All male patients and obligate carriers. We'll come to obligate carriers in next slide. They should be tested to determine the factor 8 or factor 9 mutation, which will help us in this identified mutation will help us in detecting at-risk carrier females. This diagnosis will help us in determining the prenatal diagnosis, whether the fetus is affected or not. So diagnosis of a mutation testing is important in each case, either obligate carrier or a male patient, whoever we have, and this identified mutation will help us in prenatal diagnosis. In some other scenarios, like difficult cases, where we don't know the diagnosis, whether it is factor 8 deficiency or von Willebrand disease, or we have a female with low factor 8 or 9 levels, we need to know what is going on. In such cases, we need mutation testing to confirm the diagnosis of carrier or disease. Carriers can be at risk or obligate. So first we will understand what are obligate carriers and rest would be at risk. So obligate carriers are those which we know for sure are carriers. So one example would be daughter of a person with hemophilia. If the father is suffering from hemophilia, he has to give one X chromosome to the daughter. So this daughter is going to be an obligate carrier. Other case scenarios where we will be such where a woman has one son and other family member, either a carrier or a diseased. So if a woman is linked between two members in the family, one with the disease or both with the disease, or one with the disease and other with a confirmed carrier, then that lady is an obligate carrier. So obligate carriers sample can be used to identify the mutation if we don't have the Broband case. Looking at the mutation, intron 22 gene inversion is the most common identified gene defect in hemophilia, 40 to 50% cases. So that is the first gene defect that we seek when we test for hemophilia A, followed by inversion of intron 1, which is less common, gene inversion. If both the tests are negative, then we look for point mutations. If point mutations are also not there, then we look for long gene relations, and that is done by MLPA. But when we do mutation testing, we should counsel the family that in some cases, in approximately 1% of cases, we may not actually find any genetic defect, and there are new defects being recognized over time. When we test a sample, treat a sample for mutation, for identifying whether the baby is affected or fetus is affected or not, in that case, first step is to rule out the maternal contamination of the fetal blood. In such cases, we can test by VNTR, that is variable number tandem repeats, or single STR single tandem repeats, to identify whether there is any maternal contamination or not. In that case, that sample is not the right sample. And this sample is usually collected in fetus by chorionic venous sampling or amniocentesis or photosynthesis, depending upon the gestational age of the fetus. So we have the diagnosis, but what about the patient who was bleeding? While the diagnostic workup is being done, how to manage the patient? So we know the patient has acute hematosis, the ecchymosis are there, ABTT is prolonged. In that setting, earlier the protocol was rest, ice compression, and elevation of the joint. So ice should be applied intermittently every 15 to 20 minutes for 5 to 10 minutes, not more than 6 hours in a day. Otherwise, it may interfere with the coagulation system itself. As I talked to you earlier, lower temperature also leads to activation of the coagulation cascade and deterioration of the factors. Then came rice. Earlier it was rice, then came rice. It was realized that protection of the joint, affected joint, is also important, along with the pain control. And now it has come, the revised guideline says BULLIS, which means protection, ice application, compression, elevation remain the same, and optimal loading of the joint. We should start mobilizing the joint as soon as feasible under the factor cover. Why pain occurs in the joint? Whenever there is a bleed in the joint space, there is stretching of the capsule, and this stretching of the capsule is painful and requires pain control. Paracetamol is a safe drug, and if it is not enough, then we can use COX-2 inhibitors or combine paracetamol with tramadol or movie. NSAIDs should never be used. Regarding to the management of the coagulation defect, so whether we should use FFP or cryoprecipitate. The advantage of FFP is that it has factor 9 as well. So when both factor 8 and 9 are present, then before we have identified the defect, we can use it to control the bleeding. whereas cryoprecipitate does not have any factor 9. So in a patient of known hemophilia A with volume overload, we would prefer to use cryoprecipitate as it is a concentrated preparation. 1 ml has a higher unit. But when we are still evaluating, we would prefer to use F50. And 1 ml has roughly 1 unit of factor 8. Looking at clotting factor replacement, the armamentarium includes standard half-life products, extended half-life products, as well as non-factor therapy. Besides these, we have our old generation products, desmopressin, tranexamic acid, epsilon aminocaproic acid. Trenexa and epsilon aminocaproic acid are antifibrinolytic agents. They are more useful where the fibrinolytic activity is more prominent, like in oral cavity, nasal cavity, GI bleeding. EACA is not preferred because of a higher risk of side effects, especially mild. How the treatment of hemophilia has evolved over time. Initially, whole blood was used in the early 19th century. This was followed by fresh frozen plasma. Then came cryoprecipitate, which was discovered by Jul'23. Revolution came when lyophilized preparations were available commercially. So that changed the life of the patient. But this, there was a drawback. There was a higher risk of HIV infection. In order to counter that, viral inactivation of this commercially available product was started, and that, along with the recombinant factor products, has revolutionized the treatment of hemophilia A and B. Now, we also have extended half-life factors. Few lines we'll discuss rest in the detail. It leads to less frequent infusions because the half-life is prolonged. It leads to better adherence because the frequency is reduced. Rough levels are higher, and hence it leads to better reproduction. So it leads to better control of the disease as well as better compliance for the patient. Non-factor therapies we'll discuss. Looking at the factor 8 protein structure, it has got 6 domains, A1, A2, B, A3, C1, C2. You see that B domain has no actual function, but it contributes to the significant length of the molecule. And B domain deletion is the name you will be coming across in various products. So this is a technique which makes the product commercially viable for the manufacturers. It does not give actually any added advantage to the product, like whether von Willebrand factor binding is improved or any activity is improved or any half-life is changed. It just makes the product rapidly multiply and commercially more viable. Looking at the desired target levels for CNS bleed, so this is for the bleeding patient, that is why I put this drop. For bleeding patient, we look at the site of bleed. So for a CNS bleeding, optimal dose in a resourceful setting would be 80 to 100 units per deciliter. Whereas in resource constrained setting, we choose to give around 50 to 80% factor levels. And lower levels are acceptable for the rest of the setting. How do you calculate your dose? For factor 8 and factor 9, there is a difference. We look at the percentage of desired factor 8. Whatever we are targeting, 80%, 100%, 60%, 40%. And we are using the desired factor 8 or we use desired rise in factor 8. It is one and the same thing, because when the patient comes to us with spontaneous bleeding, the levels are already less than 1%. We multiply it by body weight. Each unit of factor 8 will raise the level by each unit per kg of the factor 8 will raise the level by 2%. Hence, we multiply it by 0.5. For factor 9, each unit per kg of factor 9 will raise the factor 9 level by 1% only. So we use a multiplication factor of 1. Here, I want you to notice that factor 9 recombinant factor 9 recovery, it is less as compared to the plasma derived. So here we are using plasma derived factor I am talking about. So with recombinant factor, the recovery is less. So we use a multiplication factor of 1.2 or 1.4 depending upon the product. So commonly we use 1.5. Also, it is important to know the half-life. Factor 8 has a half-life of 8 to 12 hours. So in case of bleeding, it is given twice a day. Whereas factor 9, the standard half-life product that we are talking about, the half-life is approximately 18 to 24 hours. So it is given once a day. It is given slow IV bolus after reconstitution of the lyophilized powder with the solution that is provided with the product. So how do you calculate factor 8 dose? If you want to, our patient, the levels we want the joint bleed, so we want to target with 40%. This weight is 25 kg. We will multiply 25 by 40 and 0.5. So dose comes to 500 unit, which is given twice a day for 3 to 4 days till the symptoms subside, till especially the swelling goes away. That same child, if the diagnosis is now hemophilia B. So if the dose is plasma derived or recombinant factor, the dose will be different. In this case, we use multiplication factor of 1 for the plasma derived. So the dose comes to 1000 units once a day for 3 to 4 days as half-life is more. For recombinant factor, the dosage remains OD, but the multiplication factor is increased as the extraction of recombinant factor in the plasma is less for the recombinant factor products. So it's important to know the preparation of factor 9 when we are treating the patient. Next case is the case of hemophilia A with oral bleed. There is a history of oral of hemophilia A, and he comes with a history of oral bleed. There is no joint bleed. So do we really need factor replacement in this case? In such cases, we can first try firm pressure. We can apply ice. We can give tranexamic acid locally by dissolving the tablet in little amount of water and apply over it. And also we can give it orally. So factor replacement therapy as first line is not necessary unless the bleeding is severe or it is persistent or recurrent, especially if it is a mucocutaneous bleed. So this is a patient who has history of irregular factor 8 use and now comes with gross hematuria. Would you like to give antifibrinolytic agents in this case? Basically, the concept is that they should not be used. They are contraindicated in urinary bleed. As they may lead to the clot formation due to the inhibition of fibrinolysis. Next case, it is important and I want you all to listen to carefully. A 3-year-old male child comes with severe headache, vomiting, and irritability. His Glasgow Coma scale is low. He also has multiple ecchymosis. So, who of you would like to image this child first? It is very important you do the factor replacement as the first priority. We don't wait for any confirmation of the IC bleed. We can do it later on. This factor VIII replacement will not harm the child, but delay may cause losing the child if it is intracranial bleed. Simultaneously, we should be doing raised ICP measures, and imaging can be done later on. It is important because that will help us in deciding the duration of the factor replacement. Here it will be prolonged for 20 to 21 days. So initial levels of factor VIII are different, and this is followed by the maintenance dose, which is lower. It was found that moderate hemophilia patients seldom experience spontaneous bleeding, and that is how they are different from severe hemophilia patients. Professor Mary noticed this and used the concept of prophylaxis. The purpose is to convert a case of severe hemophilia A into moderate or mild hemophilia by raising the factor level above 1%. So here in this picture, you see that this cutoff red line is for 1%, cutoff for severe factor deficiency. After the administration of factor 8 or 9, the levels go into the non-hemophilia stage, then mild hemophilia stage, and moderate hemophilia stage. So before they touch 1%, we should be administering second dose again. It is known to decrease the annual joint bleed rate to less than 3 per bleed per year. So less than 3 bleeds per year is the target that we are looking at with the prophylaxis. Prophylaxis can be primary, that is after the initial diagnosis of the first joint bleed, you promptly investigated the patient and patient was started on the factor VIII replacement, and that is usually before the onset of, before the child is 3 years old. Secondary prophylaxis, when the workup was delayed or the resources were limited, the prophylaxis was started after 4 more bleeds, but the joint damage was established, usually in older child. Tertiary prophylaxis after the setting of joint disease. It is important to know the category because then it helps us to compare the results of the prophylaxis among different studies. So, how intense the prophylaxis can be for both hemophilia A and B? We have 3 options. Either we use low dose prophylaxis, intermediate dose prophylaxis, or high dose prophylaxis. In low dose prophylaxis, we use lower dose and less frequent administration, like 2 to 3 times per week for factor VIII and 10 to 15 units per kg per dose 2 times a week for hemophilia B, as it has a longer half-life. But it is important to know if the patient comes with a history of intracranial bleed or leg bleed, life-threatening bleed in the peritoneum, etc., then we are not going to start this patient on low dose. The patient should be on intermediate or high dose prophylaxis. And also, if the patient once started on low dose has frequent breakthrough bleedings, we need to switch, we need to titrate what kind of protocol that we have. We need to switch to a higher dose. So it is important to know that this many pricks, this is given intravenously. It is to be given for the lifelong, which affects the compliance of the patient. Before we go to the extended half-life factors, I would like to comment upon the factor availability in India under National Health Mission. As of 1st March 2020, factor coverage is available in all these dark green states as well as light green states. The brown color states are still lagging. The extended half-life products, as we talked about, improve the compliance as well as control the bleeding rate. So we aim to reduce the joint bleeds, but to even below 3 joint per year. We want to have no bleed per year. That is not now the new target for the development phase. So how the half-life of a product can be increased? Either we fuse a product with polyethylene glycol, as we do it for different pharmaceutical preparations already in the market, or we use FC portion of IgG fusion. And what this does is, it's an interesting concept. It leads to salvage of the factor proteins. The proteins are recycled in the lysosomes. They are not degraded. Or we combine with human animal. So pegylated preparation, we have this adenovate for factor VIII. We have this acrylics for FC factor IX preparation, which is combined with FC portion of IgG. And we have Lixia, which is again pegylated combined factor IX. So these are preparations, they are expensive. But how they fare in the market, in the real world, we'll look at now. So what was found with extended half-life factor VIII? From thrice a week, the frequency was reduced to twice a week, which makes it a reduction of around 30 to 35%. In contrast, with factor IX, extended half-life products, the frequency was reduced from twice a week to once a week, approximate reduction of around 50 to 60%. So why so? Why these products are not, why adenovate is not as effective as Refixia? Because we know that this factor VIII circulates in our body in combination with 1 milligram factor. And the half-life of 1 milligram factor is 16 hours. So whatever we give in whatever form is going to ultimately combine with a factor in circulation, and its half-life will remain almost as the half-life of 1 milligram factor. New product, I'll come here. This is still in waiting under research, where the recommended factor VIII is combined with 1 milligram factor in a preparation itself, so that the half-life is expected to be much longer. looking at the beneficial effects of extended half-life products. This is standard half-life products. You see, this blue area is the time the patient is at risk of spontaneous bleeding. Whereas with extended half-life products, the duration is reduced. And moreover, it is convenient to the patient. Next is non-factor therapy. So far, products that we dealt about were clotting factors, either standard half-life or extended half-life, and were to be given intravenously. Now we switch gears and we come to different preparations whose mode of administration is also different. So factor 8 replacement can be either in the form of mimetic, that is emicizumab. We'll come to the product later. MIM8, MIM8 is again factor 8. So mimetics are not available for factor 9. This product is still under investigation. There is emicizumab is available in the market with the name of Hemophilia. Rebalancing agents, what they do is, instead of promoting the coagulation factor that we were doing in the mimetic, we are trying to reduce the anticoagulant system. Fitusiran is a most common research molecule currently. It inhibits antithrombin, and these two are antibodies which inhibit the tissue factor pathway inhibitors. So the both inhibit the inhibitors, leading to the activation of the tissue factor pathway and promotion of the coagulation system. Coming to the emicizumab molecule, first we will look at what the BTT pathway looked like. So here factor 8 was interposed between factor 9 and factor 10. Similarly, here emicizumab is interposed between activated factor 9, which leads to binding to emicizumab, which in turn leads to factor 8 activation. So you can see this will not be effective in factor 9 deficiency. It's only for hemophilia A. It does not replace the missing factor. There are no peak and trough levels of the curves of protection. We'll come to the diagram later. The dose is, we have flexibility. Either we give 1.5 mg per kg per week, or we give 3 mg per kg every 2 weeks, or we give 6 mg per kg every 4 weeks. It is not meant for breakthrough bleeding. Administered subcutaneously, it is only for factor 8 deficiency. We'll come to its use in inhibitors. Regarding rebalancing of the coagulation system, normally there is a balance of procoagulant as well as anticoagulant proteins. In hemophilia, factors are lower, so you can see the balance is tilted towards anticoagulant proteins. If we remove a portion of this, the balance would be restored, and that is what fitusiran does, antithrombin B, and these two antibodies too, they are inhibitor of the inhibitors, so promoting tissue factor 1. They are, as you can see, they are not factor specific. So they can be used in both hemophilia A or B. They can be used with or without inhibitors. They are meant for prophylaxis. They are not meant for treatment of the disease. And they are currently investigation. So you can get MCQ in your exams. So it is important from theory point of view. Gene therapy can be done by either adenovirus associated vector, which has an advantage that it goes and settles directly in the liver with the transfected gene. The other option would be use the lentivirus, which will cause gene, which is used to transfer gene ex vivo, and then that has to be administered into the body through something like an autologous bone transfer. So body cells are taken out, transfected with gene ex vivo, and then infused back, and they kind of settle in the body. So that is more riskier, needs conditioning of the body with chemotherapy, whereas this engineered technique, adenovirus associated vector, would directly transfect the liver, which is the source of factor 8 and 9 synthesis. And that is the current recommended technique. Research is going on. And you can see with hemophilia A gene therapy, initially the levels are high and then they decline rapidly, but over time the rate of decline slows down. Peptide gene that is used for factor 9 is quite famous for producing a lot of factor 9 and has been used for gene therapy as well as it is used for exogenous producing recombinant factors in commercial setting. You can see the factors level are quite sustained. It is investigational. Currently in India, I think CMC Vellore has done few cases. We'll talk about it. So the graphs I was talking about, looking at standard half-life products, the hemostasis corresponds to the factor level. Standard half-life, as it increases, the activity, hemostatic activity also increases and decreases. Similarly, for extended half-life factors, the curves correspond. For non-factor therapy, we don't have any factor levels in the blood. We just have either mimetics or rebalancing agents, and the activity is maintained quite well enough. This is the cutoff 1% for the severe hemophilia for spontaneous bleed, and this is the ideal prophylaxis that the guidelines are recommending nowadays, like about 5%. So this will prevent bleeding in a more efficient manner, and the target would be to reduce the joint bleed rate to less to 0. Coming to gene therapy, it leads to factor replacement and corresponding hemostatic activity. After the factor replacement, we look at the complications that we are likely to encounter. So either can be life-threatening bleeds or can be musculoskeletal complications, transfusion-transmitted infections, and the inhibitor formation. Looking at musculoskeletal complications first, target joint. So what is meant by target joint? Or any joint which has 3 or more spontaneous bleeds in the last 6-month period. So this 3 bleeds is different from annual joint bleed rate. That is the expected joint bleed rate over a period of 1 year. This is a target joint which has been bleeding. Same joint which has annual joint bleed rate is any bleed, not just joint, any muscular bleed also. This is a one particular joint which has a tendency to bleed again and again and has already bled 3 or more times in last 6 months. The reason it is important is that there is synovial thickening and increased proliferation of vasculature in this second synovium, which is more fragile and tends to bleed more, leading to a vicious cycle. So these ankles are more commonly affected, and they do come in a flex position as the joint space is increased and it's the most comfortable position. There is a body swelling, range of motion is decreased. You can appreciate some muscle wasting here. They usually don't respond to factor. There may be some pain and some warmth, and that is how they differ from the acute bleeds. Prevention is the key. So we should begin physical therapy or optimal loading that I talked to you about earlier as soon as the pain symptoms stop. So it's not the factor replacement you give and our job is over. We need to condition the patient for physical therapy and educate for the source. Our purpose is to prevent this triple deformity, the famous triple deformity that is common in hemophilia patients who are not on factor replacement. There is posterior subluxation of the tibia. There is flexion deformity as well as valgus deformity. So this is not the want in a patient. That is why we are doing factor replacement as well as physical therapy. It involves quadricep strengthening, hamstring strengthening, as well as joint mobilization. Till the joint wages and previous bleed status is restored. Moreover, the patient should be encouraged for activities, physical activities. They should not be sitting and reading in home and watching TV. They should be doing exercise, yoga, running, walking, cycling. These are the kind of activities they should be taking and avoiding high-risk sports that would be like contact sports or high speed like cricket ball and things like that. But if they want to do it, then in such cases, if the patient's lifestyle permits or patient intends to do high-risk activities, we should not be prohibiting it. Rather we should be doing high-dose prophylaxis So our prophylaxis is tailored according to the patient's needs, and then they can take up whatever activity they want. Vaccination is important. We need to look at the hepatitis B vaccination status of the patient. And if not, then they should be vaccinated. All the routine vaccination to the children should also be given. So how to circumvent the defect in the population system in such scenarios? If we can use a subcutaneous vaccine like hepatitis B can be given subcutaneously, we should use this rather than IM or intradermal. Some vaccines cannot be given subcutaneous like DPT. In such cases, we should apply ice for 5 minutes before the vaccination. We should use a fine needle, and after injection, we should apply pressure for sufficient duration of time. Earlier, there was controversy whether factor VIII replacement just prior to the vaccination would lead to increased inhibitor formation due to the immune activity going on while vaccination. But current guidelines recommend that they should be given and just prior to the vaccination to prevent the hematoma formation. Next important topic, inhibitors and hemophilia. So it is important to know when to look for inhibitors and how to manage patients with hemophilia who have inhibitors and who come to us later. Neutralizing IgG alloantibodies to exogenous factor 8 or 9 would lead to inhibition in the action of factor that we are administering to the patient. But in some cases, they may still, the factor 8, which is released endogenously, our own factor, may still be affected because it may be mutated and may not be susceptible to alloantibodies. But we don't take any risk and we treat the patient as having no factor antibody. Who is at risk? Severe hemophilia A is more likely to have inhibitors. The incidence is like 30%. And regular prophylaxis decreases the risk of inhibitors. So regular prophylaxis is important. Besides protecting the joint, it also decreases the risk of inhibitor formation. Hemophilia B is less likely to have inhibitors, but some mild to moderate hemophilia will also have inhibitors. So risk factors for inhibitors besides race, family history, genotype, and the genetic makeup, it is important to note that the intensity of the factor replacement is an important contribution to the inhibitor formation. So when the patient has come to us post-bleeding, first diagnosis, at that time we are intensely treating the patient. That is the time when the patient is at risk of inhibitor formation and should be frequently tested. Also, when the patient is planned for surgery, I'll come to that. That is again, the patient is receiving a lot of factor and is at high risk of inhibitor formation. Recombinant factor 8 in studies has proposed higher risk of inhibitor formation versus plasma-derived factor 8, but the newer studies, they don't put the risk as significant, statistically significant. So the guidelines don't recommend switching to plasma-derived with the risk of transmitted infection. Still, the guidelines recommend factor 8, recombinant factor 8 over plasma-derived factor 8 for hemophilia. How to quantify the inhibitor? First of all, whether we have to label a patient whether he is having hemophilia inhibitor or not. So some titer may be inhibitors may be there circulating in our body. If the intensity or the report is more than 0.6 Bethesda unit for factor 8 or more than 0.3 Bethesda unit for factor 9, the patient is known as having inhibitors. Besides the titer, it is important to know whether it is low responding or high responding. Please listen to this, you won't understand clearly in the books. So a low responding inhibitor, besides having low titer, that is less than 5 Bethesda unit, is important because there is a less risk of anamnestic response after re-challenge. So in such patients, the levels are less than 5 Bethesda unit. We don't say it as low titer inhibitor, we say low responding inhibitor because these patients are less likely to have a peak of inhibitor after administering a dose of factor 8. And that is how they are managed. We'll come to the management. and they tend to be transient, that they tend to disappear within 6 months. They may not disappear, but still there is less risk of anamnestic response, and that is why they are called as low responding inhibitor. A high responding inhibitor is where the titer is more than 5 betlets per unit. These are likely to be persistent, may fall as well, but they respond briskly to the factor challenge. That is, they have a brisk anamnestic response. That is why they are called as high responding inhibitors. Why it is important? It is very important in the management. So when should we check for inhibitors? So there are like several things. Most important is before and after elective surgical procedure. You don't want to take a patient of hemophilia for an elective procedure which could have been postponed or avoided. And now the patient ends up in bleeding and you can't do anything about it. So before taking a patient for any elective surgical procedure, it is very important to look for inhibitors. Your clotting factors may not work if the titers were high. And after elective procedure, surgical procedure, as I talked earlier, whenever there is intense exposure to factors, the body reacts by forming antibodies. So antibodies which were negative earlier may come positive after a surgical procedure because of intense exposure of the factor 8 or 9 antigen. Also, it is important when you are having a patient who is having bleeds despite the factor replacement, there is a suboptimal clinical response, as well as the ABTT stays prolonged. In such cases, you want to see whether the compliance is the issue, but if compliance is adequate, then you should look for inhibitors. Another setting is anaphylaxis. It's more common with factor 9. You give factor 8 and or factor 9 and the patient crashes, who has fever reactions. You want to see what is going on. You want to screen for inhibitors. Management of inhibitors in hemophilia A and hemophilia B is different. So from here, I am bifurcating. Again, in hemophilia A, a patient with inhibitor may present with acute bleed or may come to you for prophylaxis. So hemophilia A with bleed and without bleed. So with acute bleed, you look at the titers. So if they are less than 5, you can challenge the patient with factor 8 and it's going to work. You try to use a high dose which can overcome the inhibitors. For high responding inhibitors, titer is more than 5. In such cases, we need recombinant factor 7 or activated prothrombin complex concentrate. So what is recombinant factor? This should be activated factor 7. Activated factor 7 is the market preparation, Novo 7 that is available to us. So this is 7A. It is a PT pathway. So what it will do is it will activate the factor 10A. It will activate the factor 10 to factor 10A and your fibrin generation will proceed. FIBA is APCC. It has, besides activated factor 7A, FIBA has other factors which are in inactivated form like 2, 7, 9 and 10. But activated factor 7 is also there. So since this is activated factor 7, this is to be given IV. So management of inhibitors in hemophilia A with acute bleed, you need to give IV therapy. This is also given IV, and since it is already activated, it is not to be given in prophylaxis. So no activated factor is given for prophylaxis. It is to be given only in the event of acute bleed. So its half-life is short, 2 to 3 hours. So it needs to be replaced more frequently. Whereas fever has a higher half-life of 6 to 12 hours. It can be given like BD doses. But there is risk of thromboembolic events. As you can see, they both have activated factors 7 and 8. The same hemophilia A patient comes to you before bleeding. Now, for the prophylaxis, the options are again divided for low responding inhibitors and high responding inhibitors. For low responding inhibitors, the options are like we used to treat it with factor 8. We can use immune tolerance reduction with the factor 8 hemophilia inhibition. So, or we can use different products. We can use plasma derived factor, which has 1 milligram factor attached with factor 8, or we can use extended half-life factors or you can use it in combination with emicizumab, or you can use a combination of rituximab and factor VIII. So this is an immunosuppressant which will help in decreasing the titer of neutralizing antibodies. If at least the guidelines say at least one trial of ITI should be given, and if it fails, the second option is emicizumab. And for high responding inhibitors, we come to emicizumab again. Emicizumab, as we know, is a mimetic drug which is acting independent of factor VIII. So the rationale is that continuous exposure to factor VIII. Here, we are giving almost continuous factor VIII. Here, you can see we are daily administering factor VIII and on alternate day, and we are achieving almost continuous levels. This blue line is factor VIII. Red line is factor VIII activity. So this is low because of the presence of this dotted line, that is inhibitors. So these inhibitors, in the presence of continuous factor VIII, decrease in titer because of consumption by factor VIII or kind of desensitization of the immune system. Gradually, the concept is the titer of antibodies will decrease, and this will lead to appearance of activity of factor VIII, the factor VIII that you were administering. Also, what is happening is the half-life. Earlier, whatever you were giving was destroyed by the antibodies. But now, the titer of antibodies has decreased and the half-life has increased. So with this, your activity of factor VIII is there back, and now you can use your prophylaxis efficiently in your patient. And what happens in such patients? When we are giving the antibody titers, this blue line represents the antibodies, a different graph from this one. The antibodies may peak, and in such cases, when the antibodies peak, in spite of giving factor VIII, we intensify the protocol. So the concept is to decrease the inhibitor by giving intense and continuous exposure, which may take up to 3 years. Factor support. So giving this much of factor for this much period of time, at least you need to have your factor ready. You need to have a bypassing agent. You can see that for this duration, there is no factor VIII activity. And if the patient bleeds, we need to have a bypassing agent. So bypassing agent would be, we talked about earlier, recombinant factor 7A or FIBA, that is activated prothrombin complex concentration. So even that should be there with us in sufficient amount. Monitoring of the patient, this patient can, besides bleeding, have anaphylaxis. We are giving factor in the presence of already existing antibodies. Patient selection is important for the desired results, and counseling that all this effort may not give fruitful results. So all that is important. The options are high dose versus low dose. We at the AIMS, madam is here. Classically, low dose protocol is. Regarding outcomes of ITI, success is noted in approximately 45 to 80%. So patient should be counseled yet there is a 50% chance of failure. What defines success? The inhibitor titer report comes back negative. Factor VIII recovery is more than 66% of normal. As we saw in the previous chart, here there is almost 66% of the factor VIII recovery. We were giving this much, at least this much is there. And the half-life is increased to more than 6 hours. We need to decide whom to take for ITI to have successful results, because it's quite intensive. It needs a lot of resources. So patient who has low titer of less than 10 methods per unit. Their historical peak is also smaller, less than 200 methods per unit. And the genotype is also low risk. Such patients are likely to have a better result versus the other patients whom the results will be less successful. Failure, the definition is variable. Ultimate definition is that after 33 months of IDI, no success was there, is a failure. But continuing for 33 months, when you could tell earlier that maybe we are not going to succeed, is not okay. So we need to see, have interim assessment also. So it is noted that if there is failure of titer to fall by 20% over 6 months, by 6 months the titer of inhibitor is not falling, it is not going to fall by 33%. So we need to stop it. What are the predictors of failure? If the patient has been diagnosed with inhibitor more than 5 years ago and now comes to you for ITI, more likely it's not going to succeed, or the patient is not compliant and there are frequent interruptions of therapy. Coming to hemophilia B with inhibitors, it is less common. We saw severe hemophilia B only 2%. However, the risk of anaphylaxis and nephrotic syndrome is higher in those with hemophilia B with inhibitors. So they have a high risk of anaphylaxis as well as those with anaphylaxis have a high risk of nephrotic syndrome. The patient with hemophilia B starts having proteinuria, you need to check for inhibitor. So that was one of the screening indication. Regarding prophylaxis in hemophilia B patients, ITI is risky due to the risk of anaphylaxis. So World Federation suggests ITI with strong consideration for immunosuppression if we have to give ITI. Rituximab can be used along with factor 9. Emicizumab, as we saw already, would be ineffective because it binds with activated factor 9 to activate factor 10. So there is no role of emicizumab in hemophilia B with inhibitor for prophylaxis. For active bleeding, for low responding inhibitors, factor 9 can be used. Again, the risk of anaphylaxis is there, but we should be watchful for allergic reactions. For high responding inhibitors, recombinant factor 7, that is factor 7A, would be more useful than APCC because APCC has factor 9 small doses in it. So again, the risk of anaphylaxis would be higher with APCC. So limited options for hemophilia B with inhibitors. It is fortunate that we have lower incidence of inhibitors in hemophilia B. So besides the factor replacement and the physiotherapy and immunization, we need to look at the psychological and joint health monitoring as well. SF36 looks at the short form question, looks at the quality of life, your emotional well-being, social functioning, pain, general health, as well as hemophilia activities list, what kind of activities the patient is able to do, and the functional independence score in hemophilia fish. So fish has a different meaning in hemophilia monitoring. A word about the self-care. Self-care is very important for hemophilia patients. They need to tell. It starts from the aura, detecting aura. If the patient is having aura, numbing, tingling, then at that point the patient should be prompt enough to take the factor 8 replacement for the breakthrough bleeding. The parents and the patient should be conscious enough to stop their factor for the emergency use as well as for the prophylaxis use. Maintaining dental hygiene is important because brushing, they may be scared of brushing the teeth, but if that is not done properly, then calculus formation that may lead to even more bleeding. So and then physical activity. So self-care is very important. We should be educating the patients for self-care besides giving better replacement and replacement. So the radiological scoring of the joint and the physical joint monitoring. A brief comment on factor 11 deficiency. Only few families in the West have been reported. This causes mild bleeding. That to mucoputaneous, the levels don't correlate with the bleeding phenotype, and the antifibrinolytic agents and desmopressin are effective to control the bleeding. The next interesting disease I'm going to talk about is von Willebrand disease. It looks like a dreaded disease if you look at the table, how to diagnose, etc. But it's not like that actually. It is caused by either deficiency or dysfunction of von Willebrand factor. So we have to understand either it is deficiency or dysfunction. It is the most common hereditary bleeding disorder. So 1 to 2% of the population normally tests for von Willebrand disease. So if we are like over 200 people in the group, so maybe 2 to 4 people would be positive for von Willebrand disease in this group. It is most commonest type is type 1, which is autosomal dominant. So it is autosomal dominant, but we always suspect in females, namely mother is suffering from menorrhagia, daughter is also she has uh, von Willebrand disease, and we don't think of this disease when we have a male with the bleeding. We straight away think of hemophilia. Actually, it is equally common in males and females, but is more commonly diagnosed in females due to the menorrhagia occurring in females. So that is the reason. And type 1 is a mild disease. So it manifests later in age with menorrhagia. Although it is equally common in both males and females, it is more commonly diagnosed in females because of this clinical presentation. Classically presents as mucocutaneous bleeding, either epistaxis, oral or GI bleeding. Severe type is very rare, fortunately, and it may present with soft tissue and joint pain at an early. 1 milligram factor, what it looks like and what it does. It is a multimeric glycoprotein which is synthesized in megakaryocytes in the bone marrow as well as vascular endothelial cells. So there are two sources stored in the corresponding cells, platelet alpha granules, and in the Weber Faraday bodies in the endothelial cells. It is secreted into the plasma or into the endothelial tissue upon trauma. Then its functions are important. So it has a role in primary hemostasis as well as secondary hemostasis. In primary hemostasis, what it does is it helps in addition of the platelets to the endothelium as well as their aggregation among each other. And the first picture I showed you at the beginning where the platelet clump was forming, this is facilitated by 1 milligram factor. In the secondary hemostasis, it is important for factor 8 because it has a binding and protecting factor for 1 milligram factor for factor 8. If the factor 1 milligram factor is deficient in the plasma, factor 8 level would be low and the patient would be at risk of. Coming to the classification of von Willebrand disease, so it is caused by either defect in the cell, it is caused by low levels or dysfunction. So coming to the low levels. So type 1 and type 3, they are both due to the low levels. They are low because of the decreased secretion. So this is a multimeric glycoprotein von Willebrand vector, which is sitting in the Weber Faraday bodies. Some of the granules are deficient. So this is defective synthesis, type 1, type 3. Type 1 is autosomal dominant, most common we come across in adolescent girls and their mothers. So the antigen is decreased, their activity is correspondingly reduced, and factor 8 binding is correspondingly affected. So this is the most common type and autosomal dominant. Type 3 is autosomal recessive. It is so severe that the multiples, this is all totally deficient in the plasma and corresponding factor 8. So this is a patient who you may detect that factor 8 is less than 1%, and the patient may be actually 1 Willebrand disease type 3. Then the levels may be low because of the increased clearance from the body. That is called as type 1C, 1 Willebrand disease. You can see everything is correspondingly reduced as per the 1 Willebrand antigen activity as well as factor 8. So this is type 1 and type 3. Next is the function of functional defect in 1 Willebrand factor. So there are two functions of 1 Willebrand factor. First is binding to factor 8. When there is decreased binding to factor 8, this instead of this, the factor 8 is not bound, it is just hanging there. So factor 8 antigen will be reduced, activity will be correspondingly reduced, but factor 8 levels will be further low, something like the carrier state of hemophilia carrier. So this is important to know. It may mimic as a hemophilia, mild hemophilia. So it is important to know such to identify the disease of hemophilia by mutation so that we don't miss out the real cause. Factor 8 administration in such cases is not going to work. This is called as type 2 normality, depending upon the region where it was first discovered, first city where it was discovered. So after factor 8, another function is to bind to the platelets or facilitate the binding of the platelets to the endothelium. So in this case, there is decreased binding of 1 milligram factor to the platelets, that is type 2N as well as type 2A. Both have decreased binding. Either the factor the multimers are abnormal or they may be normal, but their binding is affected. So antigen factor 8 1 milligram factor is low, but activity is even more. So that is the diagnostic group there. It's same in here. So the activity is reduced. Another thing is increased binding to platelets. So type 2B. In this case, we can see abnormal blood. Patient may come to us with thrombocytopenia, may come to us with bleeding, low factor levels, 1 milligram factor levels. What happens is increased binding of 1 milligram factor to platelet leads to increased consumption of both of them and a bleeding tendency. So it is important to look at the smear. We may see giant platelet clumps in a patient with thrombocytopenia. Management involves desmopressin. What it does, it reduces the 1 milligram factor from the endothelial cells, vascular endothelial cells, and it's given either subcutaneously or intravenously or intranasally. The dose is higher than that given for nocturnal enuresis. Other drugs are tranexamic acid, cryoprecipitate. To summarize, prophylaxis with clotting factor concentrate is the standard of care. Adjuncts available to us are desmopressin, tranexamic acid, and the supportive care involves vaccination, physiotherapy, pain control, and counseling, especially counseling for the self-help. Low dose prophylaxis in our setting is the rule, with dose escalation if needed, and dose escalation if the patient has already presented with a life-threatening bleed in the past or current. Extended life factors are affected, but they are expensive as of today. Breakthrough bleeding is treated with clotting factor concentrates and is to be given till the swelling subsides and for prolonged periods in case of intravenous bleed. In case of inhibitors, prophylaxis options are IPI or emicizumab, depending upon the titles in the patient. Rebalancing agents are currently investigational. In patients with inhibitors and breakthrough bleeding, we can administer either bypassing agent or recombinant factor or factor 8, depending upon the, or factor 9, depending upon the titles in the patient. So these are my references, and I thank you for the patient.
Thank you, ma'am, for a wonderful presentation. Please stop sharing your screen. Thank you. The house is open for the questions. We have already received some questions. Now, what is the brand of oral tranexamic acid which is available?
Trenexa is there.
Okay.
Yeah, we can use Trenexa.
So, is there any difference between the doses of SHL and EHL factors required for hemophilia A?
Yeah, actually, the doses that we use will we start with the low dose prophylaxis and then we gradually build on the doses. I have personally not used extended half-life factors. 8 is not very efficacious, and 9 we have not had need so far to use extended. So I can't comment on that.
And if factor 8 is not available immediately in rural or small settings, then how to manage a severe case?
So if we know the diagnosis is a factor 8 deficiency, in such cases, we can use either fresh frozen plasma or we can use cryoprecipitate. So fresh frozen plasma should be readily available. That would be the earliest thing to do. And besides, as a supportive care, we can use IV tranexamic acid. We can also use desmopressin if we have. It will help in release of endogenous, whatever is material is there in our body till the factor is available. But it should be freely available in the market as of now.
At what point the patient should be referred to a hematologist?
So when you have a patient and you have done the basic screening test, the APTT is prolonged in as far as hemophilia is concerned, it is important. And or if it is not prolonged and you're thinking of a this coagulation defect or a bleeding defect, we should be sending the patient to hematologist. And I would like to refer to the pediatric bleeding questionnaire that I talked to in the beginning. I can share it with you and you can share it. So you need to quantitate the bleeding pre-test probability of the bleeding disorder or clotting disorder, and that will help us in deciding which patients to what extent we should be investigating. If APTT is prolonged, it is prolonged, or even if it is normal. And I talked about that slide where I showed if there is a risk of bleeding. If there is more than one side of bleeding and you can't find anything, you should be sending. Or if there are a single side of bleeding but multiple bleeds or bleed requiring transfusion or requiring intervention like resuturing, packing, etc., then we should be, or there is a family history, we should be investigating the patient thoroughly.
If we are using extended factor for hemophilia A, then frequency of factor 8 is once a day or twice a day?
For active bleeding, yeah, actually, extended half-life factor 8 is expensive, attenuate. We can use it for active bleeding like once a day, but I have no personal experience and I don't encourage use of product which I don't think is, I mean, I told talk to you in the slides also, it does not have a much difference, but it creates a lot of difference in the cost. And with the resource limited setting, we prefer to use the resources more carefully.
We welcome Dr. Jagdish Chandra sir, the course coordinator, Dr. Gauri Kapoor and Dr. Kali Mandal, who are the next speakers. Is there any comments by the esteemed faculty?
Good morning, sir. Very nice and comprehensive class, I must say. Congratulations, ma'am.
Thank you.
Dr. Jagdish sir?
Yeah, good morning. I think I must compliment Dr. Kanwaljeet for a very nice, elaborate talk on bleeding disorders. In fact, this was supposed to be on management of hemophilia, but since the change in the sequence, I requested her to include the diagnostic part as well, and she has done a wonderful job for approaching a child with bleeding disorder as well as managing hemophilia A, B, and BC as well, and one vibrant factor. There's a very interesting question in the question box. After this course, can they declare themselves as a hematologist? Well, I think one should sit
Sir,
down.
we have answered in the group that this is not vetted by any medical council, so they cannot declare them as hematologists. It's just to update the knowledge and provide a better patient care.
Yeah.
But it cannot be used because it's not with the medical council. Any degree which is recognized by the medical council, only then you can write yourself as expert.
And anyway, one should realize that there are 2 and 3 years courses. That the FNB is for 2 years in pediatric hematology, and the other is DM, that is 3 years course. So it's just 16 hours, or maybe if you extend it to half an hour discussion, 24 hours. Training is not enough to label yourself or declare yourself. That would be problematic. And as you said, it's primarily to improve the patient care and develop interest in hematology, clear some doubts if people have regarding the hematological disorders.
So we have received a message from Dr. Neeta Radhakrishnan also that many persons have become interested in becoming members of PHO.
Yeah, that is good. So that is what the purpose is. But then PHO probably does not make members now if you do not have a degree of pediatric hematology. So anyway, that is one part. And the other is that when we are thinking of trying to, manage these patients in our particular setup where you are working, one has to see that what kind of setup is available. If you are part of, this is for the attendees actually, if you are part of a, say, medical college or a large hospital setting where there's a big department, where there's a big, good blood banking services, and the cryoprecipitates and factors are available, that is a different story. And if you are running your own small setup, whether it is a nursing home or a clinic, there it's a different story. One can initiate the treatment of acute bleed even if you are sitting in a clinic and there's nothing, nowhere else you could send the patient. But more than that, probably it will not be possible to do if you are running an OPD clinic. So one has to decide what kind of situation you are working in. Different settings, that would be, it's a simple treatment to say that acute bleed, you give factor 8 and keep repeating till 3-4 days, and the bleeding subsides, and then there is this rise and price, which you could elevation and whatever cold compression, etc. is there. But it's a complex treatment overall. You need to have a physiotherapy setup. You need to have diagnostics for the inhibitors, and you need to have a free supply of all types of products, not only factor 8, whether it is standard half-life or extended half-life, but maybe factor 7A. Activated factor 7 is important to have in the setting before you plan to decide to have a comprehensive hemophilia treatment center. Those who are in the city of Delhi, I would ask them to visit the comprehensive hemophilia center in the medical college, Maulana Azad Medical College. There's a very good setup there, and obviously AIMS also has a very good setup. So wherever they want, they can visit those. So these are few comments that I would like to make, and maybe whatever other questions are there.
Thank you, sir. Thank you. There's a child with intracranial bleed, and how to know if there are any inhibitors? If this is not possible, when to think of inhibitors?
So when the patient has come to us with bleed, at that point, the priority is to manage the patient. At that point, we can test for inhibitors, but the inhibitor report will come back after some time. We can't wait even for 10 minutes. That this much of delay may cause life to the patient. So we have to administer the dose in the factor 8. If we are giving, we give 50 units per kg. We give it like 6 to 8 hourly because of the half-life in children is smaller. So we give 50 units per kg IV, and we maintain the intensity for initial few days. And in the meantime, we after initial stabilization, starting hypertonic saline, etc., head elevation, all those things, we can take the patient for screening or for the imaging also. But testing of the inhibitor happens simultaneously. If it comes back positive, then we go for factor 8. But till we have, we go for recombinant factor 7. But till we have the report, we don't automatically assume that the patient might be having inhibitor. They are at risk of spontaneous bleed, our patients, and they are irregular with their factor replacement in the government setup or even in the private setup. The mindset, the compliance of the patients is usually poor. Even if they get factor, as they grow older, they become more compliant because they have seen that with the past factor treatment, they didn't have any bleed at all. So they were okay. They probably didn't need it. So that complacency leads to the serious life-threatening bleeds. So, we don't use recombinant factor 7 if that is what you are asking. In pending report, we would rather use factor 8 in high doses. Even if there is inhibitor is present, there is some time for the anamnestic reaction to set in and neutralize the factor 8. In the meantime, the patient improves.
Thank you. How to use desmopressin in emergency?
Yeah, in emergency, it can be used. The dose is 0.3 mg per kg. It is given by IV infusion. And what it does is it releases it is useful both for von Willebrand disease as well as factor 8 deficiency. And it is not useful for factor 9 deficiency. So von Willebrand factor deficiency or factor 8 deficiency, if there is emergency, we can use 0.3 mg per kg IV, or if the patient is at home and is in a setup, it can be where IV is a problem. They can be given subcutaneously also, and it reduces the factors from their endogenous store in liver sinusoids, and it reduces the factor loads.
What value of PT and APTT is called prolonged?
So APTT, we look at more of like INR. For hemophilia, PT is not an issue. But actually what is important is not the level as such. What is important is, you can have hemophilia. I wanted to emphasize this earlier also. You can have von Willebrand disease also with normal APTT levels. So we have had patients where APTT was normal and the factors came back normal. So cutoff for factor level to affect the APTT is 20%. So first, this should be clear. If your factor level is 25-30%, your APTT may come back normal. That is important to know. This will probably be discussed in approach to a bleeding child later on also. Regarding the cutoff of normal APTT in a known hemophilia child, or when we strongly suspect, is around 35. 30 to 35 is the normal range for APTT, and above that is abnormal, and we combine it with a clinical. But if we are doing it like routinely prior to a biopsy or prior to surgery, then this is the cutoff. In a bleeding child, we would still go for the workup, even if the APTT is low.
Ma'am, what is the treatment in minor bleeding, say epistaxis in remote area?
So in that case, what you can use is you can use pressure. If it's a mucocutaneous bleeding, if it's a nasal bleed, you can apply pressure. You can apply ice. You can have ENT person, if they are there to do the nasal packing, you can do that. For oral bleeding, you can again apply pressure. You can apply ice intermittently, and you can apply this Trenexa paste. Tranexamic acid tablet you can take, mix it in small quantities of water, make a paste of it as syrup, or any liquid preparation is solution is not available, or a spray is not available, and you can apply it locally, as well as you can administer it orally in a dose of like IV dose is 10 mg per kg, oral dose is 25 mg per kg per dose, 3 times a day.
So in cases of epistaxis, the parent should apply pressure like this and keep it there for at least 5 minutes and do not check again and again, because sometimes they have a tendency to check again and again if the bleeding is still persisting, and not to remove the clots after that also.
Right. It's important not to dislodge or check.
And what is the dose of tranexamic acid?
Yeah, the oral dose is 25 mg per kg per dose, 2 to 3 times a day, and IV dose is 10 mg per kg, 2 to 3 times a day. And it can be given for 5 to 7 days. It does not have very many side effects, so it is a good drug, especially for menorrhagia and oral bleed and nasal bleed, GI, like in the luminal GI bleed. We can use it. We can use it as an adjunct in other settings of bleed also, like intracranial, etc. We can use it as an add-on.
Ma'am, there desmopressin nasal sprays are available for the NRSs. Can these be used?
So, and the nasal spray, they have a dose of like 10 micrograms only, whereas our dose would be 150 micrograms. So we would have to do like 15 spray of that, and that will be too much of liquid, which will be probably dripping down the nose only. So there are different preparations which are available abroad, which have with the name of Stimtate, and that is more useful rather than the nasal spray that we have for the
I think the tablet available called Melt, which has 60 micrograms and 120 micrograms. I think those can be used sublingual for the sublingual use.
They should be okay. I'm not aware.
I think that is most of the questions, but if you have any other questions, we'll post them in the group and we'll ask you to answer them. So thank you once again very much. And for the delegates, we'll be having a physical workshop on 3rd of September, that is Sunday. And it will be held at Chacha Nehru Bal Chikitsalayah in Delhi, auditorium of the Chacha Nehru Bal Chikitsalayah in the morning. So if anyone has to make any travel arrangements, they can do accordingly. Thank you. Thank you very much. And we'll meet at 9 o'clock next week again. Thank you so much.
Thank you, everyone.
Mr. Sushil, please.